Hello everyone. This video is about pregnancy induced hypertension, but moreover I'll be talking about preeclampsia. So what is hypertension? Hypertension is when our blood pressure is more than or equal to 140 by 90 mm of Hg. Okay, so the systolic blood pressure, if it's more than 140 and the diastolic blood pressure more than 90 on two separate examinations that are done 4 hours apart. A single examination cannot say it is hypertension. We need to do two examinations that are 4 hours apart to say it is hypertension. Now let's learn few terminologies. What is chronic hypertension in pregnancy? If the hypertension is seen before 20 weeks of pregnancy, all right, if it's a pregnant woman and if she has hypertension before attaining the 20 weeks of pregnancy, then we call it as chronic hypertension in pregnancy. And this type of hypertension, it does not come back to normal even 12 weeks after the delivery. Okay, so you do the delivery and even after 12 weeks, the hypertension does not come back to normal, then we call it as chronic hypertension in pregnancy. Or if the hypertensive female conceives, if the woman is known case of hypertension, then it's also called chronic hypertension in pregnancy. So with that, what is pregnancy induced hypertension? If hypertension is seen after 20 weeks of pregnancy, right? So before 20 weeks there is no hypertension, after 20 weeks suddenly she develops hypertension, then we believe that it's due to pregnancy, so we call it as pregnancy induced hypertension. And this type of hypertension, it becomes normal within 12 weeks of delivery. Okay, so you do the delivery and within 12 weeks it will come back to normal. What are the types of pregnancy induced hypertension? There are two types: gestational hypertension and preeclampsia. So since these are the types of pregnancy induced hypertension, so they both occur after 20 weeks and they both come back to normal within 12 weeks after the delivery. So these two features must be present in them. So what is the difference then? The difference is that preeclampsia presents with either proteinuria or end organ damage or both, whereas gestational hypertension presents with none. All right, so if only these two features are present, then we call it a gestational hypertension. But along with these two features, if there is proteinuria, if there is end organ damage or both, then we call it as preeclampsia. So here I've introduced two terms, proteinuria and end organ damage. Let's learn what are they. So proteinuria means proteins present in the urine. It is never normal in pregnancy, it's always pathological. But how much proteinuria is significant enough to call it as preeclampsia? So for that, we do several tests. In the urine dipstick, if the score is more than or equal to +2, or if the 24-hour urine protein excretion is more than or equal to 0.3 gram per liter, or if the urine protein to creatinine ratio is more than or equal to 0.3, then we can say this proteinuria is due to preeclampsia. End organ damage, we know the organs get damaged and the manifestations is according to the type of organ that is getting damaged. All right, so if the kidney is damaged, there will be raised serum creatinine level. If the liver is damaged, raised liver enzymes. If the cerebral damage, there will be several cerebral or visual symptoms. If the lung is damaged, there will be pulmonary edema. Now coming on to the types of preeclampsia, we have two types, mild and severe. So when do we call it as mild preeclampsia? We know in preeclampsia there is hypertension, right? It's a types of pregnancy induced hypertension. So it should be, so the blood pressure should be more than 140 by 90. But if it is less than 160 by 110 and if there are no signs of end organ damage, then we call it as mild preeclampsia. But if the blood pressure is more than 160 by 110 and if there are signs of end organ damage, then we call it as severe preeclampsia. But remember, we do not classify preeclampsia on the basis of severity of proteinuria. Okay, we just see if there is proteinuria or not. If there is, then we call it as preeclampsia. If not, then no preeclampsia. The next term is chronic hypertension with superimposed preeclampsia. All right, so if a hypertensive female, if she gets pregnant and after 20 weeks she develops following features, these three features. Okay, her blood pressure, it becomes uncontrollable. If there is new onset proteinuria and if there is new onset end organ damage, then we call it as chronic hypertension with superimposed preeclampsia, which means a pregnant hypertensive female, she developed preeclampsia after 20 weeks. What is eclampsia? It's simple. Preeclampsia patients presenting with seizure, it is eclampsia. All right. So generalized tonic-clonic seizures in a patient of severe preeclampsia. Here I've mentioned severe preeclampsia because eclampsia or these seizures are most commonly seen in patients with severe. But however, if they also occur in mild preeclampsia, then we can also call it as eclampsia. Right. So seizures plus preeclampsia, we call it as eclampsia. It's simple. All right, so let's say a pregnant woman with preeclampsia is admitted to your ward. So there are chances that she might develop eclampsia and you have to prevent it. So what are the signs that you look for? Okay, so signs of impending eclampsia are, there are three signs here: epigastric pain, headache, and new onset visual symptoms. So the epigastric pain, it is due to stretching of the liver capsule due to subcapsular hematoma. Headache normally can also be caused by hypertension, but this type of headache in eclampsia, it is not relieved with usual headache medications. And if you want to know the mechanism of headache, it's due to cerebral hypoxia. Or if there are new onset visual symptoms like scotoma, diplopia, blurring of vision, or vision loss, which are due to hypertensive retinopathy. Alright, if these three features are present in a patient with preeclampsia, then there are very high chances that she is gonna develop eclampsia. And then you have to treat accordingly. So to prevent eclampsia in these type of patients, we have to give magnesium sulfate. So magnesium sulfate is a drug of choice for preventing as well as treating convulsions. So convulsions means eclampsia. Next we come to HELP syndrome. So HELP syndrome, as I said earlier, severe preeclampsia can lead to eclampsia. It can also lead to HELP syndrome. So in HELP, H stands for hemolysis, EL for elevated liver enzyme, and LP for low platelet count. Okay, so if a female presents with these three features, then we call it as HELP syndrome. So here H, hemolysis. So when do we say that a female is suffering from hemolysis? So we have three features out of these, four features out of these four. If she presents with any two, then we can call it there is hemolysis. So if the peripheral blood smear is shows schistocytes, helmet cells, or Burr cells, if the serum bilirubin is more than or equal to 1.2, if there is decrease in haptoglobin or increase in LDH level that is more than 600 international unit. Out of these four, if any of the two are present, then we can say there is hemolysis. Elevated liver enzymes such as serum glutamic oxaloacetic transaminase or serum glutamic pyruvic transaminase more than or equal to 70 international unit per liter, and if the platelet count is low, that is less than 1 lakh. So these three constitute the HELP syndrome. And if I take these three features, then these are the Tennessee's criteria for diagnosing HELP syndrome. So increase LDH, increase liver enzymes, and decrease platelet are Tennessee's criteria for diagnosing HELP syndrome. In HELP syndrome, 85% have raised blood pressure, whereas in 15% the blood pressure is normal. So if I say all the HELP syndrome patients present with hypertension, then it's wrong. The recurrence rate of HELP syndrome is 4 to 7%. And here, it's very important one. HELP syndrome is more common in multigravida females, in contrast to preeclampsia, which is more common in primigravida. All right. So how do you remember this? P for preeclampsia and P for primigravida. So preeclampsia common in primigravida, HELP syndrome common in multigravida. Now coming to risk factors for pregnancy-induced hypertension or preeclampsia. If there is previous history of preeclampsia, past history of chronic hypertension, family history of hypertension, then these are all the risk factors for preeclampsia. Or presence of chronic kidney disease, primigravida females, as I said earlier, preeclampsia more common in primigravida, new paternity or pregnancy from a new partner. Okay, all right. If a female is not primigravida, which means she has already given birth, but this time the baby is from a new partner, then she also have chances of developing preeclampsia. Or if the pregnant female is suffering from diabetes or lupus or certain syndromes such as antiphospholipid syndrome or metabolic syndrome, or if there is unusual pregnancies such as twin pregnancy, molar pregnancy, or Rh negative pregnancy, then there is also chances of developing preeclampsia. How do we prevent this? If any of these above identifiable risk factors are seen, then we give aspirin. The dose is 50 to 150 milligram per day. It is started from 12 to 16 weeks of pregnancy and it is continued throughout the pregnancy. We can also give heparin along with aspirin. Why? Later on we'll study that there in preeclampsia patients there is chances of developing thrombosis. So we give heparin. Exercise also acts as preventive factor. Calcium supplementation if calcium level is low. And here smoking also acts as a protective factor for preeclampsia. What are the tests that we do to predict preeclampsia? We do uterine artery Doppler test, which is the most commonly done. And the next one is something called as giant rollover test, which we do not do nowadays. So here basically we measure the blood pressure first in the left lateral decubitus position and then in the supine position. So normally it should decrease. Alright, so left lateral decubitation to supine position, normally the blood pressure should decrease, but in case of pregnancy induced hypertension, it is increased by more than or equal to 20 mm of Hg. Now coming to the pathogenesis of preeclampsia. So here I have drawn placenta. These are the villi. These are the placental villi, and between these two villi there is intervillous space, and in these intervillous space there are spiral arteries. All right, so in pregnancy these spiral arteries, they are invaded by these cells, the cytotrophoblast cells. The cytotrophoblast cells, they will line the spiral arteries, and what they will cause is that they will dilate this spiral artery. If they dilate the spiral artery, there will be more blood flow to the placenta, so the placenta will receive proper blood flow. All right, so let's learn here. So the spiral arteries, they open in the intervillous space as we see here. The cytotrophoblast replaces the lining of the spiral artery here, and this is known as trophoblastic invasion. This will cause angiogenesis, increase the transverse diameter of artery, and if the transverse diameter is increased, the vessel will dilate, so there will be low vascular resistance. If there is low vascular resistance, there will be more blood flow to the placenta, and the placenta will be able to get proper nutrition. What really happens in preeclampsia is that this step right here, the trophoblastic invasion, it becomes incomplete. All right, so this step is affected. Why? Because of lack of vascular endothelial growth factors and the placental growth factors. So due to deficiency of VEGF and placental growth factors, there will be incomplete trophoblastic invasion, and if this step is affected, then this will also affect this last step. So instead of low vascular resistance, there will be high vascular resistance, which means the vessel will undergo vasoconstriction. So there will be vasoconstriction, which means low blood flow to the placenta. Sometimes this can also cause placental detachment and placental ischemia. If placental ischemia, this will release several inflammatory mediators into the blood. This will cause endothelial dysfunction and leaky capillaries. If the capillaries become leaky, several fluids will leak out of the capillaries. If the fluids leak out, there will be edema. And also if fluids are leaking out from the capillaries, then the blood vessel becomes concentrated with these blood cells, which we call as hemoconcentration, and this increases the chances for thrombosis. And if there is thrombosis, this will cause end organ damage. So this is how there is end organ damage in preeclampsia. And hemoconcentration is also one of the reasons why diuretics are contraindicated in preeclampsia. And also as there is less blood supplied to placenta, there will be placental ischemia, and this can also cause fibrinoid necrosis when we see through the microscope. So here in this picture you can see these are the spiral arteries. In normal pregnancy, you can see these cytotrophoblast cells. These cells are invading into the spiral arteries. They are lining the spiral arteries and they are dilating it. But in case of preeclampsia, you can see the spiral arteries, they are getting narrowed. So as we learned, preeclampsia, there is hemoconcentration and capillary leakage, which means there is loss of blood volume. So this will cause less blood supply to the brain, leading to cerebral hypoxia, and this will cause convulsions, which is called as eclampsia. So this is how eclampsia occurs in preeclampsia. If there is less blood supply, there will also be decreased renal blood flow. This will cause decreased GFR, and since the blood is not getting filtered, there will be increase in serum urea, serum creatinine, and serum uric acid level. Less blood volume means there will be less blood supply to the fetus as well. So this will cause intrauterine growth restriction, and also less blood supply to fetus means less blood supply to the kidney of the fetus as well. So there will be oliguria, and this will cause oligohydramnios. Now finally coming to the management of pregnancy-induced hypertension. We have two types, non-specific and specific management. Non-specific, we can give antihypertensive medications and anticonvulsants like magnesium sulfate, we have already discussed. In the specific or definitive management, quick delivery is done if the fetus is viable. Alright, so as we learned that the major defect here is due to placenta, right? So all of these things is causing by the placenta. So we want to remove the placenta as soon as possible. So we do the delivery even if the estimated delivery date has not reached, to remove the placenta. And if we remove the placenta, all these symptoms will be gone. But if the fetus is non-viable, then sometimes termination of pregnancy is also a choice. So that's all about preeclampsia. Thank you.